All right, everybody, hang in there with me. We're getting through these. Again, the idea is to talk about some of these things that I think it's important to expose you to and begin to bring to attention to you. Again, nothing about this is going to be tested in this course, but I think these are good things for you guys to have some exposure to. So we're talking about the regulatory, legal, and credentialing requirements. We've talked a lot about the State Board of Nursing agreed to the elements of the APRN consensus model. We talked about LACE, the Licensure, Accreditation, Certification, Education model of monitoring how we function as APRNs. You have to have at least a master's degree. You can sit for your national exam and obtain APRN licensure with a transcript showing the successful completion from your school and that you've completed the 3 Ps. You're going to have your APRN core competencies, your specific role and population competencies, and then the master's and the essentials. Your professional APRN competencies, again, the professional organizations support these competencies and that all of us follow them, but we all have our own characteristics within our own role. APRN program oversight and accreditation. So our program here just underwent accreditation with Augustana. So program credentialing includes accreditation for education program by one of the 4 agencies. Programs must meet the state education approval and requirements through the State Department of Education, which we have done here. So you're in an accredited program. The APRN competencies are specific to your role and population certification. National certification measures competence. APRNs must obtain and maintain credentialing. Certifications must be sound and legally defensible. And the programs must be accredited by the National Commission for Certifying Agencies. So again, if you ever find yourself questioning something, you always would want to make sure you're obtaining a certification that is a nationally accredited one. And before you graduate, we talk about all these things in detail again. There's programs now that are targeted to graduates who wish to add the additional population focus or to pursue a DNP for postgraduate education. I did go back to school and got my postmaster's certificate in family practice and then went on for my DNP, so that's what they're talking about there. The continued competency through recertification, so every 5 years we have to recertify because I'm duly certified as APRN, or excuse me, as ACNP and as FNP. I have to have 2 certifications maintained. Each of those require their own mandatory continuing education and clinical practice requirements. Most roles have specific requirements for the number of clinical practice hours between your years of recertification, because again, as APRNs, we have that direct clinical practice. So you have to show that you're actually having clinical practice hours to maintain your certification. Credentialing refers to the regulatory mechanism that can be applied to your program or organization. So it was when they collect and verify your qualifications, right? At the national level, you'll undergo credentialing to make sure you're eligible to sit for the exam. At the state level, you're credentialed to make sure you're within your state scope of practice, and then your institution will verify all of these as well. Changes. Titling requires that APRNs legally represent themselves as an APRN within their scope of practice and their population of foci and their role. Your second licensure meet criteria established by the State Board of Nursing and to be held to the highest level of regulation. State laws have 2 forms: statutes defined by Nurse Practice Act and rules and regulations made by state agencies. These changes make it clear to the public that each APRN holds regulatory recognition as both RN and APRN and shares uniform regulatory standards. So that is why when you see us write our names, I may say DNP, ACNP, FNP, RN. At your institution, again, we've talked about this, you'll go through the steps to seek hospital privileges. Credentialing is usually a committee then also that will review the credentialing packet. This helps if you have support from collaborating physicians. It will determine your specific privileges, and your practice should be congruent with your APRN education and your national certification. Prescriptive authority is credentialing and licensure at the state level to be able to prescribe medications. Most states require core advanced pharmacotherapeutic course and yearly CE credits to maintain prescriptive privilege. May be included in your state licensure or recognition of APRNs, or may be conferred as a separate license or authority. I have practiced in states where I had to have a separate certificate for my prescriptive authority. APRNs must understand the mechanism of legal prescriptive authority in their state and make sure you keep up with your CE hours. Or at some point in your career, you will be desperately trying to stay up at night and do CEs so that you're within compliance. To be able to hold prescriptive authority as an APRN, you have to be graduated from an approved program, have a licensure in good standing, have your national certification. You will have had at least 45 contact hours or at least 3 credit hours of pharmacotherapeutics, evidence of collaborative practice agreement if necessary, and then you will have to have ongoing continuing education hours to be able to maintain your status to prescribe. Everybody that's a prescriber will get a DEA, a Drug Enforcement Agency number to prescribe controlled substances. So your DEA number is site-specific. Some states have APRN Compact, which allows multi-state privileges for legend drugs only. Controlled substances remain subject to the DEA and state regulations. I have had 2 DEA numbers when I've practiced in different states because it was site-specific. And then you're going to get your National Provider Identifier, your NPI. Health Insurance Portability and Accountability Act, your HIPAA mandated use of a standard identifier for healthcare providers. And this is assigned by the National Plan and Provider Enumeration System. So when you apply, you'll register and you'll get an NPI. Your scope of practice describes your limits and parameters within which nurses in various APRN specialties may practice. And again, we differ from state to state. This should identify additional responsibility beyond that of an RN. Your standards of practice is defined by the profession nationally, held to the standard of practice by nursing profession and by your APRN specialty. Your standards of practice should describe basic competency levels for safe and competent practice and should be closely matched to the core competencies for the APRN within your State Board of Nursing. These are also called our practice guidelines. They provide a foundation for healthcare providers to administer safe and competent care to the patients. Cross-cut health professions disciplines and are derived from evidence-based practice and are continuously evolving. So we as APRNs need to be part of interprofessional development and part of our own definition of what or how we would define our own practice guidelines. Collaborative practice agreements and arrangements. So if you find yourself in a position where you are practicing with a collaborative agreement, they should be written as broadly as possible to allow for you to be innovative and grow. The specificity is most often based on trust and respect between the collaborating APRN and the physician colleague. There are times when people may go into practice and they may say, for your first 3 years of practice, you'll be in a collaborative agreement with this physician or these 3 physicians, and we will revisit this in 3 years and whether or not we still need this collaborative agreement and outlining an arrangement of how this is going to look and who's accountable to whom, etc. So shifting toward collaborative relationships that offer support to all parties and protect safety of patients. So again, instead of maybe an agreement that's a formal document, developing your relationships of that are collaborate, but there are ways that sometimes you may be in practice as a novice that you will find yourself under a collaborative agreement, and that would be why. Again, we should be reimbursed, and APRN should know how to contract and negotiate for services at the individual level. So be aware of how you're going to function within your facility or your role and how your reimbursement will be done and whether or not that affects your salary. Malpractice issues are ever present. All healthcare providers have malpractice. Patients are more likely to seek redress if they mistrust their provider or believe they've been harmed by the system. So building that therapeutic relationship built upon trust is always important because that's what's right for the patient, but it also helps protect you for a malpractice. You have to understand what constitutes negligence and malpractice. Negligence is a failure to act in a professionally reasonable way as a healthcare clinician and may lead to malpractice and legal action. Malpractice has to have 4 factors in order for it to be there. A duty of care must be owed to the injured party. So you had an obligation to do something or to react or to be, something was required of you by duty, and that has to be clearly defined. Accepted standard of care was breached. So you had a breach of duty. The jury of your peers, of other providers, would say, yes, the standard of practice would be that they would have done A, B, and C, and they didn't. And the patient must have sustained damage or injury, and direct causation is demonstrated. Okay, so there could be times that you failed to do, you had a duty and you didn't do it, and you went outside of the accepted standards of care, but no injury was actually done to the patient. They survived, they went through, maybe it was an extra day in the hospital, but they're not actually injured because of it. They can't sue you for malpractice. And it has to be able to be shown that because of your action is most likely the reason, or your inaction, that the injury occurred. So the ways to prevent malpractice is establish a good rapport, build the trust with the patient, and then follow your standards of care, seek collaboration, and document accurately and completely. And at some point, I agree, I would take a course in risk management to understand how these things work, to prepare yourself to practice in the way that prevents them from happening. We've already talked about the malpractice assurance. HIPAA. This is also a way that you can be held accountable if you violate something. So if you violate HIPAA, this is a legal responsibility to you now, as well as an APRN like it is as an RN. Telehealth, telepractice, and licensure portability. So the APRN Compact. Physicians and other healthcare providers, including the nurses, fall within boundaries of electronic practice and all require regulation. Enabling telehealth legislation and reform could provide the catalyst needed to ensure that all states recognize and authorize the scope of practice for APRNs. Success of telehealth dependent on ability of providers to follow patients regardless of location. And you still have to pay the multi-state license fee, but the process is expedited. So the idea is that if I'm in South Dakota and I'm doing telehealth to people in Minnesota or Iowa, to allow that fluidity to occur and make it more fast and expedited to get that done. So there's these compacts that are forming. South Dakota just passed the APRN compact. So now there's 4 states that have it, and we need 7 in order for it to be enacted. So we're getting there. I'm not going to go through that with you right now, just for the interest of time. It should be something that you guys as a professional are participating in your professional organization. You're prescribing or subscribing to the newsletters, you're being active, you're involved, you go to meetings, and you monitor your current APRN legislation. Participate in things, guys. Help us as APRNs grow and evolve. Things like participate in the test writing committees for national certification. Get involved in regulation. Seek out gubernatorial appointment to your state board of nursing. Seek appointment to the CMS panels or advisory panels, or provide public comment on draft legislation. Be active in the regulatory process. Overall, the current practice climate is felt to be positive. The continued preference of physicians is for specialty practice and away from primary care practice. Move beyond outdated regulatory collaboration language and into true collaboration is is where we are trying to go in our current climate as APRNs. Visioning for APRNs. We really want to be rid of the invisible status. We want to be valued members, leaders, and have authority over our own practice. We've already talked about many of our challenges. And again, it's important for you as an APRN to understand and value your relationship among groups that control this complex processes and systems that regulate our practice. and you will be involved at some degree of leadership in the direction to policymakers to ensure development of standards that satisfy state statutes.